Yeah, good evening everyone. This presentation about how we evaluate OSA cases, especially the Nova ENT. Mohan Reddy sir himself, this is how initial primary questionnaire looks like. There are so many questionnaires so far accepted worldwide. One is for sleepiness, one is for assessment, risk assessment, one is for symptoms. So that is all become so so elaborate. So this is very concise form how it looks. Initially we take questionnaires includes sir just depending on the severity grading was given. It was like if it is less often it was B, and if it is daily or moderate it is A. If it is very severe and intense, patient definitely needs the treatment, it is A plus. So first criteria is whether patient snore or not, and above age 50 its age itself is a risk factor. Age and male gender both are risk factors, and when that this snoring was noticed, if it is in the recent few months it's less B type, and if it is more than 1 year it's A. And how often how loud the snoring was. If it is just audible just besides to the person besides, it's a B. If it is disturbing very loud and hearing to the next room, it's A plus. That person definitely needs the treatment. And how often that person snores. Is it every day or once in few times in a week or few times in a month? And the next point is it throughout the whole sleep or sometimes it's going on and off, on and off. If it is throughout the whole sleep, the obstruction is very severe. And any other complaints along with the snoring. Patient, if it is symptomatic, the more patient symptomatic, more is the severity of the disease. Like the symptoms includes difficulty in breathing, patient wakes up with the morning headaches, and patient keep complaining about tiredness, fatigue, daytime sleepiness, and associated other problems like repeated episode of nose blocks, repeated episode of the colds, repeated episodes of the throat pain. These are all very much significant. Simple snoring is not significant. If something is disturbing the patient, that is very significant. Snoring can be simple sound, or it itself is a disease and it can contribute to other diseases. And by the time patient coming to us, they are already having treatment. They develop hypertension early in 40s. They may develop diabetes in their 30s. So we'll take other factors also. What are the comorbidities they also develop, like obesity, hypertension, heart problems, hypothyroidism, PCOS. And snoring, patients have the apneas. Apneas means if apneas per self, patient can't perceive the apneas. That can be told by partner. And if patient feeling that choking or apneas, that obstruction is very severe, then it is categorized to A plus. And if anything helps to reduce the snoring, like some people they comfortable sleeping to the sides, they sleeping in prone position, they sleep with a pillow, with raised pillows, means these are the things helping to relieve the obstruction. Something is relieving the obstruction, it's good. So it's given B. If it is not relieving any obstruction, that is a A. Depending on all the symptoms, patient was characterized into very high risk, code red was given, and high risk. Code orange, low risk is the blue, and no risk is the green. Very high risk patient, sleep study and treatment, everything is very essential. And high risk patient also, treatments are essential. Low risk patient, sleep study is optional, and treatment we can try preventive lifestyle and causative factors, we can address them. And in the whole year, these are the statistics, and we enrolled the total, and we developed a clinical examination form also. So initially we take the patient with this questionnaire and clinical examination form, and we'll put them into which category they come. We have enrolled total 44 patients, and in this very high risk category are the 39 patients, and high risk category comes to 5%. Because if the patient feels something only, they'll come to the treatment. Snoring, only simple sound, they may not come. But if they feel something only, they'll come, and most of the patients, they are into high risk category only. And number of sleep studies done was total 38, and sometimes some patients they did outside, but that's not included in this number. and total number of DICE, drug-induced sleep studies done was 14, and in all these patients, 16 patients we did septoplasty. Some patients they need multi-staged procedures. So after septoplasty they may need palatoplasty. Some patients we do first palatoplasty and tonsillectomy. Tonsils are very huge. So these multi-staged procedures with the septoplasty and palatoplasty were total 8 number of patients, and only palatoplasty is 2. But in these one patient already septoplasty done long back. Another patient septoplasty is scheduled later stage. This emphasizes the importance of multi-stage surgery. And here are some case reports. And if first case one is a 50-year male patient. Mohan Reddy sir already told this patient came very much bloated with so much of nasal congestion symptoms. Initially he was treated with the septoplasty and FES, and after the FES sleep study is done with AHI. This comes is a moderate case. AHI is 14 only, and with BMI is 28.4, means this patient is like moderately obese, moderately AHI, but this patient his main problem is uncontrolled diabetes and excessive daytime sleepiness. He can't do continuously a single work. He can't drive. If you want to long drive, he used to drive for an hour, 1 hour. We used to sleep for an hour. Like that, his daytime sleepiness is a chief complaint. But after palatoplasty and ovular reconstruction surgery, is a sleep study is reported, and surprisingly it came to 0.8. Even normal is less than 5 is the normal thing. So AHI came to 0.8, and he is comfortably living without any daytime sleepiness, and sugars are better controlled now. And now we enroll the patient into lifestyle modification program for the better control of the diabetes, and to maintain success of these kind of surgeries, preventing weight gain is very important. Even if we gain some weight, even 5 kgs, even with minimal amount of the weight gain also impair the results kind of these kind of surgeries. For that thing, we enroll the patient into the program. And this is a second case. This patient is a young patient. He is only 35 years old. His main complaints are snoring daily and morning headaches. He is looking very sick actually. Though he is 35 years old, and his examination showing he has a DNS, long palate and short neck. BMI is 33. Because of his short stature, he is not, he is only 85 kgs, but his BMI is 33. And DICE was done before no surgery. Sorry, I forgot to tell. This is his AHI is 130. 130 AHI is very, very, very high. So DICE was done before septoplasty surgery. His findings are very interesting. Is arytenoids and AE folds, they are going into his glottis with every inspiration. So that is the reason could be explaining that it's very high AHI. These kind of things we can see only in the DICE. So that DICE is very important in upper airway obstruction, in understanding what happening during the sleep. No one can see. We can only make the person sleep and see. His arytenoids are normal, glottis is normal during the sleep, during daytime. But they are blocking, they are making him to choke. That's why even in this young age also he developed so much of symptoms with high AHI number. And CPAP, I just want to mention an interesting point into the CPAP. Usually screens the upper airway at the level of the palate, tongue blaze, and it opens the airway properly. But if a patient has a floppy epiglottis or these kind of flappy AE folds, this positive pressure, it worsens the obstruction. That means it pushes the things, epiglottis, with the positive pressure jet from upside, it further pushes the things inside. Means, sir, is it okay? Mic, it's not working, sir. Now it's working. Okay, sir. So it further pushes them down. So these patients definitely they don't get benefit from the CPAP. They tell after using the CPAP, my symptoms are worsening. if someone is prescribed the CPAP, please, if that patient is telling my symptoms are worsening after the CPAP use, we should consider the obstructions, because with the nasal obstructions, especially glottis level of obstructions, they feel those obstructions are worse with CPAP. So, and even in the CPAP data, we can see that that snoring and airflow limitations, they won't improve with the CPAP, and this flow limitation pattern shows flattened inspiratory flow curve. That inspiratory flow, it get flattened with continuous pressure coming from upside, and that patient also complains choking, discomfort with CPAP use, and he feel like air hunger. He literally feels choking. So DICE, we can confirm while using, we can put the CPAP and we can do the DICE, and we can confirm those findings also in those patients. I mean CPAP non-compliance also, this is also very important. Yes. CPAP in these patients, it's making my problem worse. I can't breathe out with it. This is the thing patient told. And this patient, he is using hypothyroidism treatment for 1.5 years, and apparently is all a surgical profile and preliminary investigations are normal. But when we was done a detailed investigation to take into lifestyle disease reversal program, he has a high fasting insulin, and he has antithyroid antibodies, and high levels of homocysteine. It's a kind of, he is into stage of pre-diabetes, he is into pre-hypertension, pre-cardiac cardiac disease. Means is a picture of metabolic syndrome not evident, but we can pick up all those things in lifestyle program. And once this patient into these things, we can reverse. Means OSA already made a young person to develop into metabolic syndrome, which was not obvious, but we can reverse all these things also with the lifestyle disease program. That's why we have enrolled the patient into lifestyle program. This is a picture of all the deranged investigations, which were not usually picked up by our routine surgical profile or blood test, all those things. And this is a case 3. She's a 53-year-old female patient. She's very morbidly obese, and her main complaint is snoring for so many years with excessive daytime sleepiness. His AHA is 76, and her daytime sleepiness is so bad. While eating also, she used to eat and drop the plate and sleep. She's the sleepiness is very bad, and she has huge tonsils and long palate. That's why we have taken her for tonsillectomy and palatoplasty first place. 4 months later, we taken her for septoplasty and torbinoplasty. After the surgery, her AHA is 36. So this residual part is mainly due to her obesity, thick neck. She has very bulky double chin, thick neck fat, and bulky parotids. This all things can be reduced with this lifestyle disease program. And why to take these kind of morbid patients means even 50% of reduction of AHA is considered as a successful surgery. And relieving the obstructions will help the patient for better weight loss and better CPAP use. And this is a case for 46 years old male patient. His main complaint, he used to wake up from the sleep so many times with air hunger and choking feeling. And he is very, means he is not typical OSA patient. He is very thin built, non-obese. He is not even obese. He was evaluated so many times for cardiac evaluation, because that patient is typically telling my heart rate is going up, I am feeling so scary, I am not able to sleep properly, I am feeling choking. And his sleep study is also, AHA is 10.8 only, that is even moderate, not severe. So this AHA is not corresponding with the symptoms of the patient. But when DICE was done, he has a primary collapse of epiglottis. So that is making him choking. This means his epiglottis is closing like a door while he is sleeping. Okay. So this case signifies the importance of DICE in airway management with lesser AHA and more symptoms, especially in non-obese individuals. This all, whether it is a UARS or OSA, this is not, patient have different symptoms. OSA people, OSA they have more apneas and they sleep more. During night time, during daytime, they sleep more, they become more obese. That's a different picture. In upper airway resistance syndrome, patients usually thin, they can't sleep, they have insomnia, they can't sleep, even they want to sleep, they can't sleep more than 3 to 4 hours. They usually wake up. This kind of patient comes with upper airway resistance syndrome, but means they don't have higher AHI. Sometimes it can be diagnosed with RERA. RERA means they don't have apneas. Apneas mechanism of action on the brain is different, and RERA's action of mechanism on the brain is different. Typically they non-obese, they are more complaining of insomnia and fatigue. Not only this, there are so many cases. I pain, sir. I pain. So, yes, sir. This is finished. Sir. Yes, sir. Presentation can be different. It can be a young 16-year-old boy presented with resistant hypertension, and a young student who can't sleep because of daytime sleepiness, bank employee, manager level, he can't even sign a check because he is sleeping all the time, and some patients, they can't sleep because they have choking sensation. So for all patients, taking proper history and airway assessment, doing DICE, sleep study, and treating all the comorbidities, it's all very important for whole treatment of the patient obstructions.